Welcome to Clinical Rounds. Today we're diving straight into musculoskeletal oncology. Let's get right to it.
All right, first case. We've got a 60-year-old patient presenting with generalized weakness and back pain. Their x-ray shows these classic punched-out lytic lesions. Looking at the labs, we see normocytic anemia, a raised ESR, and hypercalcemia. So what's the most likely diagnosis here? Is it A, metastatic carcinoma, B, granulomatous disease, C, milk alkali syndrome, D, multiple myeloma, or E, hyperparathyroidism?
If you guessed D, multiple myeloma, you hit the nail on the head. The pathogenesis here is a clonal malignant plasma cell proliferation right inside the bone marrow. And those destructive lytic lesions, they're actually driven by osteoclast activating factors. Here's a crucial clinical pearl to remember. Multiple myeloma is the single most common primary bone malignancy in adults over 65. In fact, if you see unexplained back pain paired with an ESR over 100 in an older adult, it's multiple myeloma until proven otherwise. Oh, and definitely watch out for renal impairment caused by Bence-Johns proteinuria and hypercalcemia.
Okay, let's keep that momentum going. Which of the following is the most common primary tumor of bone in adults? A, osteoblastoma, B, osteosarcoma, C, multiple myeloma, D, osteochondroma, or E, Ewing sarcoma?
The correct answer is C, multiple myeloma. To put it all into perspective, in adults over 40 or 50, multiple myeloma takes the top spot. Now, if we're looking at kids under 20, osteosarcoma is number 1, followed by Ewing sarcoma. And for benign lesions in younger folks, osteochondroma or exostosis is what you'll see the most.
Next question. A 65-year-old man presents with low back pain. On physical exam, you notice macroglossia and hepatosplenomegaly. Labs show an ESR of 123 and a serum calcium of 12 milligrams per deciliter. What's the diagnosis? A, multiple myeloma, B, Hodgkin lymphoma, C, tuberculosis, D, hyperparathyroidism, or E, chronic lymphocytic lymphoma?
Spot on if you chose A, multiple myeloma. The advanced age, severe back pain, ESR over 100, and hypercalcemia are total giveaways. But what about the macroglossia and hepatosplenomegaly? Well, they actually indicate secondary systemic AL amyloidosis, which happens in about 10% of these cases. You also want to look out for periorbital purpura, panda eyes, and carpal tunnel syndrome.
Section 2. Patterns of bone metastasis. Moving right along, what is the most common bone tumor overall? Is it A, osteosarcoma, B, osteochondroma, C, Ewing sarcoma, D, metastatic tumor, or E, multiple myeloma?
And the answer is D, metastatic tumor. Listen, secondary metastatic carcinomas outnumber primary bone malignancies by a massive margin. The top primary sources in descending order are breast, prostate, lung, kidney, and thyroid carcinomas. And the axial skeleton, especially the spine, is the absolute prime target here, all thanks to Batson's venous plexus.
All right, try this one. A 44-year-old woman presents with multiple mixed osteoclastic and osteoblastic metastatic bone deposits. Which of the following is the site of the primary tumor? A, breast, B, lung, C, renal, D, colon, or E, adrenal gland?
The correct answer is A, breast. Breast carcinoma is actually the most common source of bone metastases in females, and it classically shows up with this mixed pattern. You see both destructive osteolytic areas and sclerotic osteoblastic repair areas. Compare that to prostate carcinoma, which is the most common source in males. That one presents almost exclusively as purely osteoblastic, highly sclerotic lesions.
Let's flip the script. A 51-year-old male presents with multiple purely lytic metastatic bone disease. Where is the primary tumor? A, breast, B, lung, C, renal, D, colon, or E, adrenal gland?
It's B, lung. Lung carcinoma, renal cell carcinoma, and thyroid cancer produce strictly osteolytic lesions. And the spine? It's the single most common site for these hematogenous deposits, followed closely by the proximal femur and proximal humerus. Be incredibly careful here, because these lytic spinal deposits carry a dangerously high risk of pathologic fractures and epidural spinal cord compression, which can cause acute bowel, bladder, and motor deficits.
Next up, in which of the following conditions is alkaline phosphatase raised? A, osteoporosis, B, metastatic breast cancer, C, osteopetrosis, D, hypervitaminosis,
or E, none of the above?
The answer is B, metastatic breast cancer. You see, serum alkaline phosphatase, or ALP, is a marker of osteoblastic repair activity. Since breast cancer triggers a local osteoblastic repair response, the serum ALP spikes. You'll also see ALP rise in Paget's disease, osteomalacia, and even healing fractures. But baseline ALP remains totally normal in osteoporosis and classical osteopetrosis. And just for context, in hypervitaminosis D, your calcium and phosphate go up, but that baseline ALP, it stays perfectly normal.
Next section, rare primary bone tumors. Let's get right into it.
Which condition is associated with a high risk of malignant disease in bone and cartilage? A. Osteonecrosis. B. Chronic osteomyelitis. C. Paget's disease. D. Radiation osteomyelitis. Or E. Maffucci syndrome.
The correct choice is E, Maffucci syndrome. Now, both Maffucci syndrome and Ollier's disease feature multiple enchondromas. But here's the catch. Maffucci syndrome uniquely pairs those enchondromas with visceral or soft tissue hemangiomas. And those angiomas drive the risk of malignant transformation into chondrosarcoma to practically 100% over a patient's lifetime. Ollier's disease, on the other hand, lacks those diagnostic soft tissue angiomas.
Let's try this one. Which of the following sites is the most common location for adamantinoma? A. Radial epiphyses. B. Ulnar metaphases. C. Femur diaphysis. D. Tibial diaphysis. Or E. Humeral diaphysis.
The answer is D, the tibial diaphysis. Adamantinoma has this very unique predilection for the anterior cortex of the mid-tibial diaphysis. We're talking up to 90% of cases. On imaging, you're looking for a classic soap bubble appearance. It's often correlated with osteofibrous dysplasia, and let me tell you, it requires aggressive, wide-margin surgical resection.
Moving to our final section, tumor biopsy best practices. Okay, a patient with a suspected malignant bone tumor is referred to a specialized center. Which type of biopsy should be taken? A. Excisional biopsy. B. Incisional biopsy. C. Needle biopsy. D. Wedge biopsy. Or E. None of the above.
It's C, needle biopsy. You absolutely want to perform a closed-core needle biopsy. Use a Jamshedai for bone and a TrueCut for soft tissue. Why? To limit tract seeding and prevent hematomas. If an open biopsy is absolutely mandatory, you have to plan that incision meticulously. The entire biopsy tract must be resected during the definitive limb salvage surgery. Remember, poor planning here literally forces amputation.
To wrap this all up, secondary metastatic carcinomas outnumber primary bone malignancies by a vast margin. But if you fail to suspect myeloma in an older adult or misplace your biopsy incision, the diagnostic war is lost before it even begins. So what will you look for first on your next set of rounds?